There are two types of bladder cancers: urothelial and non-urothelial types. The urothelium is a special type of transitional cell epithelium that forms a stretchy, protective barrier in the bladder. The majority of primary bladder tumors are urothelial cell carcinomas, also known as transitional cell carcinomas, that obviously originate from the urothelium. Somewhat confusingly, non-urothelial tumors like squamous cell carcinomas and adenocarcinomas also often arise from the urothelium layer, but are distinguished by the way that their cells differentiate. For example, the normal bladder surface isn't normally lined with squamous epithelium, yet the cells in the urothelium can change shape and take on a flat, pancake-like appearance of squamous cells. This non-cancerous change is called squamous cell metaplasia. If these cells start to grow unchecked, they can turn into squamous cell carcinoma. These tumors typically pop up in multiple locations and show extensive keratinization, which is where the cytoplasm of the cells is filled with keratin, the same tough material in hair and nails. Squamous cell carcinomas typically arise in response to chronic irritation, like from recurrent urinary tract infections and long-standing kidney stones. Another cause, common in some parts of the world, is an infection with schistosoma hematobium, a type of flatworm. In this infection, the infective larvae linger in the water and then burrow into human skin when given the opportunity. Then they travel to the liver and mature into adult flukes. From there, the young flukes migrate to the urinary bladder veins to sexually reproduce and lay eggs in the bladder wall. These eggs can get urinated out, but they also cause chronic inflammation in the bladder wall, which is how they lead to squamous cell carcinomas. Primary adenocarcinomas of the bladder are more rare, but unlike squamous cell carcinomas, they frequently metastasize. These are usually solitary and derived from glandular tissue, so they can often produce a lot of mucin. Adenocarcinomas are the main form of bladder tumors in patients with bladder exstrophy, which is where the bladder protrudes through a birth defect in the abdominal wall and partially or completely sits outside of the body. Adenocarcinomas can also develop in response to schistosoma hematobium infections. And finally, it's worth noting that adenocarcinomas of the urachus are pretty similar to bladder adenocarcinomas. The urachus is the fibrous tissue sitting at the dome of the bladder, which serves as the remnant of the allantois, the canal that allows urine to flow from the fetal bladder into the amniotic sac. These non-urothelial bladder cancers typically present with bladder irritation and red blood cells in the urine, a condition called hematuria. Since adenocarcinomas often secrete mucin, these cancers can also cause an excess amount of mucus in the urine, called mucosuria. Even though it's relatively rare, mucosuria as well as an abdominal mass is most commonly associated with urachal adenocarcinomas. To diagnose a cancer of the bladder, it's often helpful to use a cystoscope, which is a thin tube fitted with a light and a camera that's inserted up the urethra and into the bladder, a procedure called a cystoscopy. Definitive diagnoses of squamous cell carcinomas and adenocarcinomas is based mainly on the cellular morphology of a resected tumor. Small tumors can be resected with a cystoscope in a procedure called transurethral resection, or TUR. But larger invasive tumors might need a radical cystectomy, which is complete removal of the bladder along with dissection of the surrounding lymph nodes. With urachal adenocarcinomas, the bladder dome, urachal ligament, and umbilicus are all generally removed. Alright, as a quick recap, non-urothelial bladder cancers are a small subset of bladder cancers that confusingly often arise from the urothelium. Squamous cell carcinomas are made completely of squamous cells, while adenocarcinomas are composed completely of glandular cells. These cancers often arise due to chronic inflammation of the bladder, especially from cystosoma hematobium infection. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. The most common form of cancer in the lower urinary tract, or the bladder and the urethra, is transitional cell carcinoma, or TCC. And to be more specific, urothelial cell carcinoma, or UCC. While this cancer can affect tissues in the upper urinary tract, like the renal pelvis and the ureter, it most commonly arises in the urothelium of the bladder. The urothelium, or uroepithelium, is a specific type of transitional cell epithelium that lines the inner surface of much of the urinary tract. This tissue is composed of 3 to 7 cell layers, and it forms a tight barrier that holds urine without allowing toxins to move across the epithelium and back into the body. That barrier functions largely accomplished by large umbrella cells that line the inner or luminal surface of the urothelium, and are held together by high-resistance tight junctions, and are lined with a unique protein-lipid complex, called a plaque, along their apical membrane. Now, when you think about the bladder, it's going to cyclically change shape during the course of its normal function. For example, after you chug a tall mango lassi, your bladder will become completely filled up, only to be emptied again when you rush to the bathroom. Therefore, the urothelium has to be able to maintain its impermeable properties during these normal changes in bladder shape. Most of this is allowed for by the unfolding of the mucosal surface when the bladder fills up. When the bladder is empty, this surface is highly wrinkled with rugae, which then smooths out as the bladder becomes distended. In addition to this, these umbrella cells of the urothelium have the ability to stretch with an expanding bladder. In fact, the term transition of transitional epithelium refers to this ability to go through transitions of shape. Cancers that affect the urothelium usually arise through 2 distinct mechanisms. One way for a urothelial cell carcinoma to come about is through a mutation in the tumor suppressor protein p53. Mutations in p53 can allow urothelial cells to start growing horizontally, kind of like a flat pancake, some of which start to invade deeper bladder tissues. The other, less aggressive way for a urothelial cell carcinoma to come about is independent of p53 mutations, and occurs when finger-like extensions called papillary tumors grow outward from the urothelium, although these can occasionally invade deeper bladder tissues as well. Regardless of the cause of the urothelial cell carcinoma invasion, a telltale sign of the presence of cancer is the presence of red blood cells in the urine, a typically painless condition known as hematuria. To make a definitive diagnosis, it's possible to look at the inside of the bladder with a cystoscope, which is a thin, flexible tube fitted with a light and a camera that's inserted up the urethra and into the bladder, a procedure called cytoscopy. This tool can also be used to take biopsies, which are used for subsequent histological analysis. Urothelial cell cancers most commonly happen in older patients, and have been linked to various carcinogens. One way to remember some of these well-known causes is the phrase, "having trouble with your pee sac?" which has a fairly helpful mnemonic. P stands for phenacetin, which was a common analgesic until it was banned by the FDA in the 80s, in part because of its link to urinary tract cancers. S stands for smoking, which is the biggest risk factor, giving you yet another reason to not pick up the habit. A stands for aniline, which is an organic compound used in rubber and dye manufacturing. And C stands for cyclophosphamide, which is a medication used to treat cancers and autoimmune diseases, which has a toxic effect on the bladder. Heavy alcohol use and chronically having extended dwell times of urine in the bladder, think about truck drivers that don't pull over very often to use the restroom, are also linked to urothelial cell carcinomas. Unfortunately, these cancers can be difficult to treat because they're often multifocal and can recur after treatment. One theory for why this happens is called the field effect, where the entire urothelial field is exposed to a carcinogen, and therefore many of the cells are equally susceptible to tumor formation. Another theory is the implantation theory, where tumor cells detach from one location in the bladder, float through the urine, and then implant themselves at another location in the bladder. This could also explain why these cancers are prone to metastasize to nearby structures. If the tumors are localized, non-invasive, and obvious, they might be able to be resected with a cystoscope in a procedure called transurethral resection, or TUR. This is often followed up with localized chemotherapy delivered to the bladder via catheter, which is called intravesical chemotherapy. If the cancer is more aggressive, a complete removal of the prostate and the bladder, or a cystoprostatectomy, is sometimes done, often in conjunction with chemotherapy. Alright, to recap. Transitional cell carcinomas are the most common form of cancer in the lower urinary tract. These cancers affect the highly elastic urothelium and are often associated with carcinogens, remembered by PSAC, phenacetin, smoking, aniline, and cyclophosphamide. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Bladder exstrophy is a congenital abnormality that results in an inside-out bladder, where the bladder protrudes out of the abdomen, leaving the inside of the bladder exposed to the outside environment. Normally, in the first trimester, endoderm in the hindgut expands to form the cloaca, which is a temporary structure that connects the urinary, digestive, and reproductive tracts. Separately, the ectoderm forms the anterior abdominal wall. At around 8 weeks of development, 3 important things happen. First, the anterior abdominal wall matures and forms the muscles and connective tissue of the lower abdomen. Second, the cloaca splits to form the urogenital sinus and rectum. The urogenital sinus later goes on to become the urinary and genital ducts, as well as the urinary bladder. And third, the cloacal membrane opens up to the outside of the body, creating openings for the urogenital tract and anus. Alright, so bladder exstrophy happens when the developing bladder and urethra herniate anteriorly, and this causes a couple problems. First, it prevents the normal development of the lower abdominal wall, which leaves it open. Second, it prevents the fusion of the pelvis, which leaves a wide split in the symphysis pubis. Also, most cases of bladder exstrophy involve epispadias, which is where the urethra exits the top of the penis. But the opposite isn't true. Not all cases of epispadias involve bladder exstrophy. One way to kind of think about the final result is to imagine the bladder and the urethra. Then make a cut through the top of the urethra and bladder. And also imagine that that cut goes up through the symphysis pubis, as well as the abdominal wall. After that, imagine pushing on the bladder from the bottom until it's inside out. And this is essentially what the final defect in the bladder exstrophy looks like. And that bladder pushes through the abdominal wall into the outside world. In addition to this, bladder exstrophy causes other changes as well. For example, the anus is usually more anteriorly located. Also, in boys, the anterior part of the penis is shortened, and in girls, the vagina is wider and shorter, as well as more vertically oriented. The exact reason that bladder exstrophy happens in some infants is unknown. But one theory is that the mesenchymal cells fail to migrate between the endoderm of the cloaca and the ectoderm of the anterior abdominal wall. Without mesenchymal support, the cloacal membrane becomes unstable and opens up to the outside prematurely. And this creates a hole in the lower abdominal wall, which exposes the internal structures, like the bladder, to the outside. Having a bladder and urethra exposed to the outside environment can lead to complications, like incontinence, as well as an increased risk of urinary tract infections. As far as diagnosis goes, the defect's clinically obvious when a baby's born, but it can also be diagnosed earlier on a prenatal ultrasound. Generally, within the first few weeks of life, the bladder and urethral defect are surgically closed, but sometimes staged surgeries are needed over months or even years. Alright, as a quick recap. Bladder exstrophy is a congenital problem where the bladder protrudes through the front of the abdominal wall, and it's often accompanied by epispadias. Bladder exstrophy can cause incontinence and increase the risk of urinary tract infections, and requires early surgical correction. What's up, guys? Tanner here. Just want to give a little special thanks to Amanda for writing the script on that one. As always, you guys can help support us by donating on Patreon, as well as subscribing to our channel and telling your friends about us on social media. Thanks, guys. Bye. With hypospadias and epispadias, the prefix hypo means below, epi means above, and the suffix spadius refers to a slit or opening. So instead of having an opening at the tip of the urethra, hypospadias refers to an abnormal opening on the bottom of the urethra, and epispadias refers to an abnormal opening on the top of the urethra. And both of these can happen in boys and girls, but are way more common in boys. During genital development in the fetus, there's a point in the 8th week of gestation when both boys and girls have a similar bit of tissue called the genital tubercle, which normally grows in the cranial direction, meaning that it grows towards the head. After that point, in boys, the genital tubercle responds to the hormone dihydrotestosterone and stretches out a bit into a primitive phallus. As it grows in length, an area of tissue on the underside called the urethral plate invaginates to form a urethral groove, which is lined with epithelial cells. In the 14th week of gestation, the 2 urethral folds on the sides pinch off the groove to make it close, and form the penile urethra. In the 17th week of gestation, the ectodermal cells of the glans penis, or head of the penis, also undergo a process of canalization, and the urethral canal connects with the penile canal, and that means that the urethra eventually meets the outside world at the tip of the penis. In a boy, hypospadias happens when the urethral folds along the penile urethra don't meet up and close properly, and that leaves an opening somewhere along the bottom of the penile shaft, and urine can leak out at that spot, instead of going out the tip of the penis like it should. Anatomically, hypospadias can happen in 3 areas: glandular, which is near the head of the penis, midshaft, which is the middle of the penis, and penoscrotal, where the penis and scrotum come together. Generally, the least severe hypospadias are glandular, and the most severe are penoscrotal. Now, with regard to epispadias, the problem starts during the 6th week of gestation, when the genital tubercle grows in the posterior direction, towards the rectal area, instead of the cranial direction. In a boy, this results in an opening along the upper surface of the penis. And anatomically, epispadias can happen in 3 areas: penopubic, where the base of the penis and the abdominal wall come together; penile, which is just somewhere along the penis; and again, glandular, near the head of the penis. Generally, the least severe epispadias are glandular, and the most severe are penopubic. Alright, so switching gears to girls, during development, estrogens stimulate the development of the external genitalia. In this case, the genital tubercle only gets a little bit longer and then forms the clitoris. Here, the urethral folds and groove don't fuse, but instead create the labia minora and the vestibule. In the 13th week of gestation, the urethra forms, and is situated anterior to the vagina and is shorter than the one in boys. Hypospadias results in the urethra opening into the anterior vaginal wall, whereas epispadias results in the urethra developing too far anteriorly. Now, the precise cause of hypospadias and epispadias isn't fully understood, but seems to be related to fetal exposure to abnormal levels of androgens and estrogens. Of the two, hypospadias is more common, and they're associated with other conditions like chordee, which is when the penis has a hook shape and curves inwardly, inguinal hernia, which is a protrusion of bowel through the inguinal canal, and cryptorchidism, which is the absence of testes from the scrotum. Epispadias, on the other hand, are usually associated with bladder exstrophy, where the bladder sticks out through the abdominal wall, and in females they're often associated with a bifid clitoris, which is where the clitoris itself is divided into 2 parts. Symptoms of hypospadias and epispadias largely depends on the location of the abnormal urethral opening. In boys, the symptoms can range from making it slightly difficult to target the urine to incontinence. In girls, the diagnosis often happens later in life, and can cause frequent and painful urination, as well as recurrent urinary tract infections. As individuals mature, if the problem's left untreated, it can lead to sexual dysfunction, infertility, and psychosocial problems, especially in intimate relationships. The diagnosis of both hypospadias and epispadias is typically made when examining a newborn infant. Imaging studies like an excretory urogram can also be used to help with the diagnosis, and this is where a series of x-rays are used to visualize substances passing through the kidneys, the bladder, and the urethra. To treat both hypospadias and epispadias, surgery can be done to reconstruct the urethra, close up the defect, and allow urine to come out the tip of the urethra. This is usually done within the first 2 years of life. Sometimes hormone therapy can be useful as well, especially when there's an additional problem. For example, in a boy with a micropenis, which is an extremely small penis that results from low androgen levels during development. Finally, infants with hypospadias shouldn't have a circumcision, because the foreskin might be useful for future reconstruction. Alright, so as a quick recap, epispadias and hypospadias are generally seen in boys, although they can happen in both sexes. In boys with hypospadias, there's an abnormal opening on the underside of the penis, whereas with epispadias, there's an abnormal opening above or on top of the penis. Fortunately, both can be surgically corrected so that urine flows out the tip of the urethra. Posterior urethral valve, or PUV, is a congenital disorder in boys where the posterior urethra, which is the section of the urethra nearest the bladder, is obstructed by membranous folds, or flaps of tissue. These flaps of tissue are collectively referred to as a congenital obstructive posterior urethral membrane, or CUPUM. This blockage means urine can't easily flow out, which leads to a backup of urine, which can cause kidney problems, as well as less amniotic fluid, which can cause respiratory problems. Although the cause of PUV isn't completely understood, it's thought that normal development of the male urethra is disrupted between weeks 9 and 14 of gestation. Normal development involves the Wolffian duct integrating with the posterior urethra, which results in thin mucosal folds called plici colliculi. It's thought that PUV might result from abnormal integration of the Wolffian duct, resulting in large plici colliculi that fuse anteriorly, making it more difficult for urine to flow through. When that urine can't easily flow out because of increased resistance from the obstruction, the intravesical pressure, or bladder pressure, starts to creep up. Holding urine under higher pressure leads to bladder wall hypertrophy and collagen deposition, both of which thicken the bladder wall. This thickening makes the bladder less compliant, meaning that small increases in urine volume causes large increases in bladder pressure, which makes the problem even worse. That high pressure urine has nowhere to go but up to the ureters and eventually to the kidneys, causing hydronephrosis, which is the swelling of a kidney due to a buildup of urine. In PUV, since the bladder outlet's obstructed, the hydronephrosis is bilateral, meaning it affects both kidneys. Severe obstruction in utero can also lead to oligohydramnios, which is a low volume of amniotic fluid, since normally a significant proportion of amniotic fluid comes from fetal urine, and also that amniotic fluid normally gets breathed into the developing lungs, which helps expand the airways and also provides the amino acid proline, and both of these things are critical to normal lung development. Therefore, with less amniotic fluid, the lungs might not develop completely, called lung hypoplasia, and as a result, some newborns have respiratory distress. Another complication of PUV includes vesicoureteral reflux, since increased bladder pressure can also lead to dysfunction of the ureterovesical junction, where the ureters enter the bladder, which results in reflux of urine back up into the ureters and the kidneys. PUV also causes urinary stasis, which can allow bacteria to get into the urinary tract and cause a urinary tract infection. Over time, recurring infections and injury to the kidneys can lead to chronic kidney disease, which might progress to end-stage renal disease. Often PUV can be diagnosed by prenatal ultrasound, which can show a dilated bladder, thickened bladder wall, and bilateral hydronephrosis. If not found prenatally, though, postnatal diagnosis might be done by voiding cystourethrogram, or VCUG, which shows a dilated and elongated posterior urethra. Treatment involves surgery and ablation of the membrane, which allows the urine to flow through unobstructed. Prenatal surgery, though, can be risky, so it's typically reserved for severe cases of oligohydramnios and possible lung hypoplasia. Postnatally, the standard surgery is transurethral catheter ablation. Alright, as a quick recap. Posterior urethral valve, sometimes more descriptively referred to as a congenital obstructive posterior urethral membrane, is a congenital condition in boys where membranous folds obstruct the normal flow of urine. And this leads to bladder outlet obstruction, which causes high bladder pressure, which can cause vesicoureteral reflux, which results in reflux of urine back up into the ureters and kidneys. That obstruction also, though, leads to urinary stasis, which can lead to recurrent urinary tract infections. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Vesico refers to the bladder, and ureteral refers to the ureter. So vesicoureteral reflux means that urine's refluxing, or getting backed up. Normally, urine flows in one direction. It starts in the kidneys, goes down into the bladder, and when the bladder's full, urine flows out of the body through the urethra. In vesicoureteral reflux, there's some obstruction in that path, which causes pressure to build up and a current of urine actually pushes backward from the bladder into the ureters and kidneys. Now, there are two types of vesicoureteral reflux, or VUR for short. Primary VUR is the most common type, and happens when a child's born with a defect at the ureterovesical junction, which is the spot where the ureter enters the bladder. And this spot also acts as a valve, which prevents urine from pushing back from the bladder into the ureter. Normally, about 2 centimeters of the ureter sticks into the bladder wall, which allows urine to flow into the bladder. But as the bladder fills up and stretches, it also stretches out that section of the ureter and presses it against the top of the bladder, which causes the ureter to close shut. If the tube isn't long enough, though, that small piece of the ureter doesn't stretch very much, and it stays open even when the bladder fills with urine. In that situation, as the bladder pressure builds with more urine, it starts to go back up into the ureters. In secondary vesicoureteral reflux, there's an obstruction at some point in the urinary tract, causing urine to follow the path of least resistance, which often means flowing backward into the ureters or kidneys. Secondary VUR is most commonly caused by recurrent urinary tract infections, which can cause inflammation in the ureters, which makes them swell up and close. Another cause that's often diagnosed in babies is called posterior urethral valve disorder, which is when an abnormal membrane develops in the posterior part of the urethra, or the part closest to the bladder. And this prevents urine from easily passing from the bladder into the urethra. Yet another cause is a flaccid neurogenic bladder, which is when the bladder is unable to contract to release urine out of the body, even when a person's consciously trying to release the urine. This most often results from trauma, disease, or injury to the nervous system. VUR is usually classified by severity, grade 1 through 5, depending on how far the urine refluxes back up into the urinary tract. Grade 1 is least severe, and urine only goes up into the ureters. In grade 2, urine fills the entire ureter and the renal pelvis, which is the center part of the kidney. In grade 3, urine fills and starts to stretch both the ureter and the renal pelvis. In grade 4, the ureter is so swollen that it starts to get curvy, and the renal pelvis and calyces, which are the urine collection ducts, become moderately swollen and distorted. Finally, in grade 5, the most severe classification, urine fills up the ureter, pelvis, and calyces, which causes them to swell up completely. And this amount of pressure can lead to kidney failure. Individuals with milder cases show no symptoms. But in severe cases, urine lingers in the urinary tract for so long that there's very little flow through the urethra, which allows bacteria to move up the urethra and cause an infection. Chronic vesicoureteral reflux can cause pyelonephritis, or inflammation of the kidney, as well as renal scarring, or fibrosis, which damages the kidney tissue. This damage can also reduce blood flow to the kidneys, and they can respond by holding on to more fluid to raise the blood pressure, which can ultimately result in hypertension. Vesicoureteral reflux can be diagnosed with an abdominal ultrasound, which can detect blockages in flow of urine and swelling in the ureters or kidneys. Another test, called a voiding cystourethrogram, or VCUG, can show how urine moves through the ureterovesical junction. In a voiding cystourethrogram, a contrast dye is injected into the bladder through a catheter, and X-ray images are taken to see if the dye moves from the bladder up into the ureters and kidneys. Another technique, called a radionuclide cystogram, uses a similar procedure as VCUG, except that it uses a radioactive tracer injected into a blood vessel. The scanner then detects the tracer as it moves from the blood and into the kidney, and then down through the ureters and into the bladder. Treatment for VUR depends on severity and age, since it mostly affects young infants and children. As a child grows, the ureter gets longer and the function of the valve improves. So primary vesicoureteral reflux sometimes improves or disappears over time. Some individuals might also need surgery to remove a blockage or to repair the valve at the ureterovesical junction. Alright, as a quick recap. Vesicoureteral reflux is a condition where pressure in the urinary outflow tract increases and urine gets pushed back up into the ureters or kidneys. Primary VUR is usually due to a short ureter, while secondary VUR is usually due to a blockage in the urinary tract. This disease often leads to urinary tract infections that can cause renal inflammation and scarring. Hey guys, thanks for watching. Hope you liked that one. It was actually done by our other illustrator, Vincent, so huge props to him on that one. In other news, we actually just made a subreddit called r/osmosit. So if you're a Redditor, you should go check it out. And if you're not a Redditor, you should also go check it out. Although I know Reddit can be a little intimidating at times. Otherwise, you can always donate to us on Patreon or subscribe to our channel or follow us on social media. You know, all that good stuff. All right. Bye, guys.
Lower urinary tract infections, or lower UTIs, primarily include infections of the urinary bladder and urethra, called cystitis and urethritis respectively. Most UTIs are caused by bacteria that typically compose the normal gastrointestinal flora, especially gram-negative rods such as E. coli, followed by Klebsiella pneumoniae and Proteus mirabilis. Depending on the setting and patient's risk factors, lower UTIs can be classified as uncomplicated, complicated, CAUTI, and UTI in pregnancy. All right, if a patient presents with signs and symptoms suggestive of a lower UTI, you should first perform an ABCDE assessment to determine if they are unstable or stable. If unstable, first stabilize the airway, breathing, and circulation. This means you might have to intubate the patient, provide supplemental oxygen, obtain IV access, and monitor vital signs before doing further workup. Now that you know how to manage unstable patients, let's go back to the ABCDE assessment and discuss stable ones. If your patient is stable, you should first perform a focused history and physical examination, and order labs like a urinalysis and urine culture. History might reveal symptoms like dysuria, urinary frequency and urgency, and sometimes even blood in urine. On the other hand, physical exam could reveal suprapubic tenderness to palpation. As far as labs go, The urinalysis will be positive for nitrites and leukocyte esterase and will reveal pyuria or WBCs and possibly hematuria or RBCs. Now here's a clinical pearl to keep in mind. It's important to note whether hematuria is painful or painless. Painful hematuria suggests diagnoses like infection or nephrolithiasis. On the other hand, painless hematuria can be a sign of underlying conditions such as renal malignancies, polycystic kidney disease, or autoimmune rheumatologic conditions such as IgA nephropathy. At this point, you should suspect a lower UTI. Now, if your patient is a healthy, premenopausal, biologically female individual with no systemic symptoms like fever or chills, as well as no vaginal discharge, you should suspect an uncomplicated lower UTI. Next, start empiric antibiotic therapy with medications that cover most types of gastrointestinal flora, like nitrofurantoin, trimethoprim sulfamethoxazole, or TMP-SMX, or fosfomycin. If urine culture reveals growth over 100,000 colony-forming units per milliliter, it confirms the diagnosis, so consider tailoring antibiotics based on culture results. Now, here's another clinical pearl. Uncomplicated lower UTIs are especially common in biologically female individuals due to the proximity of the urethra to the rectum. The urethra is further away in biological males, so they are less likely to develop UTIs. And for that reason, they're always considered complicated lower UTIs, regardless of the severity. Moreover, a UTI in a biological male individual can resemble other conditions like prostatitis. You can differentiate this based on additional prostatitis symptoms like pain in the pelvis, perineum, or penis, a slow dribbling urine stream, and systemic symptoms like fever. If so, perform a digital rectal exam to check for prostatic hypertrophy and order labs to look for an elevated prostate-specific antigen, or PSA for short. All right, now let's move on and talk about complicated lower UTIs. These include UTIs that occur in biological males, as well as in elderly, immunocompromised, and renal transplant patients, or in any patient who presents with systemic symptoms like fever and chills, or as a result of urinary obstruction, instrumentation, and urinary catheters. Keep in mind that complicated UTIs might be caused by resistant organisms, so you should initiate empiric antibiotic therapy with more broad-spectrum antibiotics, such as fluoroquinolones, TMP-SMX, or third-generation cephalosporins. Next, obtain blood cultures to rule out bacteremia. If urine cultures come back positive, with or without a positive blood culture, you can make the diagnosis of complicated lower UTI. So tailor antibiotics based on culture results. Okay, if a patient is pregnant and has urinary symptoms, it's important to suspect UTI in pregnancy and not wait for urine culture results. This is important because a UTI during pregnancy can lead to dangerous perinatal and neonatal infections. Next, begin empiric antibiotic therapy with ampicillin or cephalosporin, and avoid certain commonly used medications like TMP-SMX and fluoroquinolones, which can harm a developing fetus. A positive urine culture confirms the diagnosis of UTI in pregnancy, so tailor antibiotics based on culture results. Now here's another high-yield fact. Sometimes there's bacteria in the urine, but no urinary symptoms. This is called asymptomatic bacteriuria. While it's not a true UTI, in certain at-risk populations, including pregnant patients or those undergoing a genitourinary procedure, it can still lead to complications like pyelonephritis, preterm labor, or neonatal infections. So make sure to treat it with antibiotics, just like symptomatic infections. Finally, let's talk about catheter-associated UTI, or CAUTI for short. This is a lower UTI in the setting of indwelling urinary catheters. If your patient has signs and symptoms of a UTI and has an indwelling urinary catheter, as well as systemic symptoms like fever, you should suspect CAUTI. In this case, start empiric antibiotics and be sure to remove or replace the catheter while waiting for urine culture results. If the urine culture is negative, consider alternative diagnoses. However, if the urine culture is positive, it confirms the diagnosis of CAUTI, so use the results to tailor the antibiotic therapy. Additionally, consider adding antifungals if the culture grows yeast. Alright, as a quick recap, lower UTIs primarily include infections of the urinary bladder and urethra, called cystitis and urethritis. If you suspect lower UTI, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If unstable, stabilize the airway, breathing, and circulation before continuing the workup. In a stable patient, look for symptoms like dysuria, frequency and urgency, and signs like suprapubic tenderness, as well as urinalysis positive for nitrites and leukocyte esterase, pyuria, and hematuria. If the patient is a healthy premenopausal female and has no systemic symptoms, you can suspect uncomplicated lower UTI. Treat with empiric antibiotics, and once you get culture results, consider tailoring antibiotics. On the other hand, consider complicated UTI in biological males, as well as in elderly, immunocompromised, and renal transplant patients, or in any patient who presents with systemic symptoms like fever and chills, or as a result of urinary obstruction, instrumentation, and urinary catheters. Next, order blood cultures to rule out bacteremia and start empiric antibiotics for the suspected UTI. If urine cultures come back positive, with or without a positive blood culture, you can confirm the diagnosis of complicated UTI and tailor antibiotics based on the result. If a patient has asymptomatic bacteriuria, they don't need treatment, but if the patient is pregnant or undergoing a genitourinary procedure, treat empirically with antibiotics to prevent complications. Finally, if the patient has an indwelling urinary catheter, suspect CAUTI, treat with empiric antibiotics, and tailor the antibiotics when the urine culture results are available.
With cystitis, cyst refers to the bladder, and itis refers to inflammation. Therefore, cystitis describes an inflamed bladder, which is usually the result of a bacterial infection, but also can result from fungal infections, chemical irritants, foreign bodies like kidney stones, as well as trauma. Now, a urinary tract infection, or UTI, is any infection of the urinary tract, which includes the upper portion of the tract, the kidneys and the ureters, and the lower portion of the tract, the bladder and the urethra. So cystitis, when it's caused by an infection, is a type of lower UTI. Lower UTIs are almost always caused by an ascending infection, where bacteria typically move from the rectal area to the urethra, and then migrate up the urethra and into the bladder. Having said that, on rare occasions, a descending infection can happen as well, where bacteria starts in the blood or lymph, and then goes to the kidney and makes its way down to the bladder and urethra. Normally, urine's sterile, meaning bacteria doesn't live there. The composition of urine, which has a high urea concentration and a low pH, helps keep bacteria from setting up camp. Also, though, the unidirectional flow in the act of urinating also helps to keep bacteria from invading the urethra and bladder. Some bacteria, though, are better at surviving in and resisting these conditions, and can stick to and colonize the bladder mucosa. E. coli accounts for the vast majority of UTIs. Also, though, other gram-negative bacteria that can infect the bladder include Klebsiella, Proteus, Enterobacter, and Citrobacter species. On the other hand, gram-positive bacteria can also cause problems, like Enterococcus species and Staphylococcus saprophyticus, which is actually the second most common cause overall after E. coli, and particularly the urine voids are small in volume. Having said that, symptoms can differ by age. Infants might have a fever, become fussy, and feed poorly, whereas elderly patients might feel fatigued, become incontinent, or even develop delirium. Symptoms that are not typically present with lower UTIs are systemic signs like fevers and nausea or vomiting, as well as pain at the costovertebral angle, which is the angle formed on either side of the back between the 12th rib and the vertebral column. If any of these do occur, though, this might suggest an upper urinary tract infection, which includes an infection of the kidneys themselves. If a urinalysis is done, there might be signs of inflammation, like pyuria, the presence of white blood cells in the urine, which can make the urine appear cloudy. Having a couple white blood cells in the urine can be normal, but it'd be considered abnormally high if there are more than 5 white blood cells per high-powered field on microscopy, or more than 10 white blood cells per milliliter on a hemocytometer. Similarly, a dipstick test might show the presence of leukocyte esterase, which is an enzyme created by leukocytes, or white blood cells. It might also be positive for nitrites, since gram-negative organisms like E. coli convert nitrates in the urine to nitrites. But it's worth remembering that not all uropathogens are able to do that. Alright, and finally, a urine culture is the gold standard for diagnosis, and is considered positive if it shows more than 100,000 colony-forming units per milliliter from a clean catch urine sample. Although a lower number of colony-forming units per milliliter might still indicate an infection, depending on the source of the specimen and the specifics of the clinical scenario. And remember that this test assumes that the bacteria that grows is a known bacterial cause of UTIs, and that the patient has clinical symptoms. Now, if there's pyuria but the urine culture doesn't reveal a bacteria, this is known as sterile pyuria, and it suggests urethritis, inflammation of just the urethra, as opposed to cystitis. Isolated urethritis is most commonly caused by Neisseria gonorrhea and Chlamydia trachomatis, both of which are sexually transmitted infections. For a UTI, imaging studies can also be helpful. For example, a renal ultrasound can be used for children who might have a kidney malformation, which could contribute to developing a UTI. In addition, a voiding cystourethrogram, or VCUG, might be used, which is where someone's given a radiocontrast liquid and fluoroscopy, which are like real-time x-rays, and then they watch how that fluid gets urinated out. And this is particularly helpful in children with severe or recurrent UTIs to detect evidence of vesicoureteral reflux, which is the retrograde movement of urine from the bladder back up into the ureters and kidneys. The degree of vesicoureteral reflux can vary, and it's an important risk factor for kidney scarring with a UTI. Finally, in some situations, renal scintigraphy using DMSA, which is a radionuclide, sometimes called a DMSA scan, can be used to detect evidence of kidney scarring. Treatment for a lower UTI is usually antibiotics, targeted to the bacterial cause, and then those symptoms usually clear up within a few days as the urine becomes sterile. At the same time, pain medication might also be given. Preventing UTIs mainly involves drinking lots of fluid to help flush out bacteria that might try to ascend up the urethra, and emptying the bladder as often as possible, which is especially relevant for women after sexual activity. And finally, maintaining good hygiene, like wiping from the urethra to the rectum, all of which are aimed at preventing fecal bacteria from making it up the urethra. Alright, as a quick recap, cystitis is inflammation of the bladder, usually caused by bacterial infection, which makes it a type of lower urinary tract infection. E. coli is by far the most common culprit, and risk factors include female gender, sexual intercourse, having catheters, diabetes mellitus, having penile foreskin in infant boys, and urinary stasis. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
In the urology ward, 2 people are coming in. The first is Oleg, a 70-year-old man who says that he frequently has to use the bathroom and also complains of a weak urinary stream. The second is Samantha, a 55-year-old woman who says that she pees a little when she laughs. Samantha also has 2 children, and both were born by vaginal delivery. Now, both these individuals seem to have urinary incontinence. Urinary incontinence is a problem where the process of urination happens involuntarily, meaning that a person might urinate without intending to. This is particularly problematic because it affects a person's personal hygiene, as well as their social life, in a way that can be very limiting. Let's talk about physiology real quick. Okay, so as urine flows from the kidneys into the bladder starts to fill. Lining the bladder is a layer of transitional epithelium containing umbrella cells. These cells physically stretch out as the bladder fills, just like an umbrella opening up in slow motion. This expansion is further aided by the relaxation of the muscular layer within the bladder's walls, called the detrusor muscle. At some point, the bladder fills up with urine that will eventually exit the body through the urethra. Now, the urethra is wrapped up in some muscles that can prevent urine from leaking out. The first one is the internal sphincter muscle, which is made of smooth muscle and is under involuntary control, and typically opens up when the bladder is about half full. The second one is the external sphincter muscle, and it's made of skeletal muscle and is under voluntary control. This is the reason that it's possible to stop urine midstream by tightening up that muscle. Once urine has passed through the external sphincter muscle, it can no longer be stopped. Now, when specialized nerves in the bladder wall sense that the bladder is about half full, they send impulses to the spinal cord at levels S2 and S3, also known as the micturition center, and to the pons of the brain. The spinal cord response is part of the micturition reflex, and it causes an increase in parasympathetic stimulation and decrease in sympathetic stimulation, which makes the detrusor muscle contract and the internal sphincter relax. It also decreases motor nerve stimulation to the external sphincter, allowing it to relax as well. At this point, urination would occur if not for the pons. The pons is the region that we train to voluntarily control urination. If we want to delay urination, the pons overrides the micturition reflex, and when we want to urinate, the pons allows for the micturition reflex to happen. Now, there are several types of urinary incontinence. The first one is stress incontinence, where urine leaks out when there's a high abdominal pressure. Then there's urgency incontinence, where there's a sudden urge to urinate. Then there's mixed incontinence, which is a combination of stress and urgency incontinence. And finally, there's overflow incontinence, when the bladder doesn't empty completely. Now let's look at them one by one. Let's start with stress incontinence, which is due to increased abdominal pressure that overwhelms the sphincter muscles and allows urine to leak out. Some activities like sneezing, coughing, or laughing increase abdominal pressure. This increases the pressure in the bladder, and in turn, urine leaks out. If the pressure in the bladder is greater than the pressure in the sphincters, then the sphincters are unable to hold urine in. For your tests, remember that if the sphincters are damaged, which is also called an outlet incompetence, then they can't stop urine from leaking out. Now, outlet incompetence can be caused by urethral hypermobility or intrinsic sphincter deficiency. Now, urethral hypermobility is a condition where the urethra can't be kept still by the muscles surrounding it because they are way too weak. One thing that can weaken the pelvic muscle is vaginal delivery. On the other hand, intrinsic sphincter deficiency is caused by damage to these sphincter muscles, which is often a complication of prostate surgery. Okay, now another risk factor for stress incontinence can be obesity, because it increases the abdominal pressure and therefore pressure in the bladder can sometimes be higher than the pressure of the sphincter. Similarly, pregnancy can also cause stress incontinence since the uterus rests above the bladder. The diagnosis can be made based on a positive bladder stress test, where you can directly see urine leaking out when a person is coughing or does the Valsalva maneuver. This is when the clinician bears down and squeezes the abdominal muscles in order to increase abdominal pressure and cause urine to leak out. Stress incontinence treatments typically focus on strengthening the pelvic floor muscles by doing Kegel exercises. In individuals with obesity, weight loss is recommended. And in females, using pessaries might be helpful. Next, there's urgency incontinence, which is when someone has a sudden urge to urinate because of an overactive bladder, followed immediately by involuntary urination. This is typically due to an uninhibited detrusor muscle that contracts randomly. This usually results in frequent urination, especially at night. For your tests, remember that urgency incontinence is usually associated with urinary tract infections. That's because the inflammation in the bladder might trigger the detrusor muscle, causing it to contract out of nowhere. For diagnosis, urodynamic studies are generally not needed, but if performed, they will show detrusor overactivity. Now, for your exam, it's important to remember that the first-line treatment for urgency incontinence relies on Kegel exercises, bladder training, like establishing a timetable for when to go to the bathroom and empty the bladder, as well as distraction or relaxation techniques. If behavioral training fails to improve the symptoms, medications such as antimuscarinics like oxybutynin can be used to decrease detrusor muscle contractions. Now, stress and urge incontinence are not mutually exclusive, so sometimes you get mixed incontinence, which is basically a combination of both stress and urgency incontinence. This could happen when, say, a pregnant person also develops a urinary tract infection. As a result, urine can leak out with increased abdominal pressure, or when there's random detrusor contractions. Finally, there's overflow incontinence, which is typically caused by incomplete emptying of the bladder. When the bladder doesn't empty completely, it fills up and overflows with urine, leading to incontinence. Typically, this results in a weak or intermittent urinary stream or hesitancy, where it takes a while for the urine to get flowing because of a blockage in the path. For your tests, remember that one cause is the blockage in urine flow due to an outlet obstruction, like with benign prostatic hyperplasia in males. Also, remember that another cause is an ineffective detrusor muscle which contracts too little and can't push out all the urine in the bladder. Now, an ineffective detrusor muscle can be caused by diabetes, in which case there will also be polyuria, or it can be caused by a neurogenic bladder that's associated with multiple sclerosis. In both cases, there's damage to the nerves that supply the bladder, so the signal for the contraction of the detrusor muscle may be weaker. As far as diagnosis goes, catheterization and ultrasound will show an increased post-void residual volume, which is the volume of urine retained in the bladder after a voluntary void. Overflow treatments are aimed at re-establishing a clear pathway for urine flow. For example, that might be through catheterization in order to empty the bladder, or medications like alpha blockers for treating benign prostatic hyperplasia in males. Okay, let's review. Stress incontinence happens when there's increased abdominal pressure, which also increases bladder pressure. If bladder pressure is greater than the urethral pressure, then urine can leak out. This can happen when the muscles surrounding the urethra are weakened, like with vaginal delivery, or if there's trauma to the sphincters, like with prostate surgery. Next, there's urgency incontinence, where there's an urge to urinate due to inappropriate detrusor muscle contractions, and it's usually associated with urinary tract infections. Then there's mixed incontinence, which is a combination of stress and urge incontinence. Finally, there's overflow incontinence, where there's incomplete emptying of the bladder. This can be due to an outlet obstruction, like with benign prostatic hyperplasia, or when the detrusor muscle doesn't contract effectively, like with a neurogenic bladder, for example. Now, back to our cases. First, there's 70-year-old Oleg who often has to go to the bathroom and also has a weak urinary stream. Well, taking into account the fact that Oleg is 70 years old, this could be a case of benign prostatic hyperplasia. So in this case, there's an overflow incontinence caused by the obstruction that's due to the enlargement of the prostate. Among other treatments, Oleg might benefit from alpha blockers. Then there's Samantha, who urinates when she laughs. If we ask Samantha to laugh or cough while we directly examine her, we might see that urine leaks out. Now, considering she also had 2 vaginal deliveries, this is most likely a case of stress incontinence caused by weakened pelvic muscles. And the problem might resolve with training in Kegel exercises.
Urinary incontinence is a problem where the process of urination, also called micturition, happens involuntarily. meaning that a person might urinate without intending to. Urinary incontinence is especially problematic because it affects a person's personal hygiene as well as their social life in a way that can be very limiting. Normally, urine's held in the bladder, which receives urine from two ureters coming down from the kidneys, and then that urine leaves the bladder through the urethra. As urine flows from the kidney through the ureters and into the bladder starts to expand into the abdomen. The bladder is able to expand and contract because it's wrapped in a muscular layer, called the detrusor muscle, and within that, lining the bladder itself, is a layer of transitional epithelium containing umbrella cells. These umbrella cells get their name because they physically stretch out as the bladder fills, just like an umbrella opening in slow motion. In a grown adult, the bladder can expand to hold about 750 milliliters, slightly less in women than in men, because the uterus takes up space, which crowds out the bladder a little bit. Alright, so when the urine's collecting in the bladder, there are basically two doors that are shut, which holds the urine in. The first door is the internal sphincter muscle, which is made of smooth muscle and is under involuntary control, meaning that it opens and closes automatically. Typically, that internal sphincter muscle opens up when the bladder is about half full. The second door is the external sphincter muscle, and it's made of skeletal muscles and is under voluntary control, meaning that it opens and closes when a person wants it to. This is the reason that it's possible to stop urine midstream by tightening up that muscle, which is called doing Kegel exercises. Once urine has passed through the external sphincter muscle, it exits the body. In women, the exit's immediate, and in men, the urine flows through the penis before it exits. So when specialized nerves called stretch receptors in the bladder wall sense that the bladder is about half full, they send impulses to the spinal cord, specifically the sacral spinal cord at levels S2 and S3, known as the micturition center, and the brain, specifically two locations in the pons, the pontine storage center and the pontine micturition center. The spinal cord response is part of the micturition reflex, and it causes an increase in parasympathetic stimulation and decrease in sympathetic stimulation, which makes the detrusor muscle contract and the internal sphincter relax. It also decreases motor nerve stimulation to the external sphincter, allowing it to relax as well. At this point, urination would happen, if not for the pons. The pons is the region of the brain that we train to voluntarily control urination. If we want to delay urination, or hold it in, the pontine storage center overrides the micturition reflex. And when we want to urinate, the pontine micturition center allows for the micturition reflex to happen. Now, there are a few types of urinary incontinence. The first is urge incontinence, which is when someone has a sudden urge to urinate because of an overactive bladder, followed immediately by involuntary urination. This is typically due to an uninhibited detrusor muscle that contracts randomly. This usually results in frequent urination, especially at night. To treat urge incontinence, the focus is on decreasing the detrusor muscle activity. Relaxation techniques to relax the bladder as well as antimuscarinic medications can decrease detrusor muscle contractions. Next, there's stress incontinence, which is usually due to increased abdominal pressure that overwhelms the sphincter muscles and allows urine to leak out. Think of things that cause exertion, like sneezing, coughing, and laughing. Anything that puts pressure on the bladder. This is also relevant during pregnancy, when a growing baby puts tremendous pressure on the bladder and causes stress incontinence in some women. The classic finding is urinary leakage with pressure applied to the abdomen. Stress incontinence treatments typically focus on strengthening the external sphincter muscle by doing things like Kegel exercises. Another type is overflow incontinence, which is typically caused by some sort of problem with emptying the bladder. This could be due to a blockage in urine flow, like a hypertrophic prostate in men, which presses on the urethra, or an ineffective detrusor muscle. Either way, the bladder doesn't empty properly, and as a result, the bladder fills up and overflows with urine, which leaks through the sphincters. Typically, this results in a weak or intermittent urinary stream or hesitancy, where it takes a while for the urine to start to flow because of the blockage in the path. Overflow treatments are aimed at reestablishing a clear pathway for urine flow. For example, that might be through catheterization or medications like alpha blockers, which can limit prostate enlargement. Finally, there are various conditions like diabetes, bladder cancer, Parkinson's, and multiple sclerosis, as well as procedures like prostatectomy or hysterectomy that can damage the nerves involved in the micturition reflex, ultimately leading to urinary incontinence. The symptoms and treatment for these problems depend on the exact condition. Alright, as a quick recap, urinary incontinence happens when urine involuntarily leaves the bladder through the internal and external sphincter muscles. Urge incontinence is due to an overactive bladder, stress incontinence is due to too much pressure for the sphincter muscles to resist, and overflow incontinence is due to incomplete emptying of the bladder. Hey guys, thanks for watching. Hope you liked that one. Special thanks goes to Vanita Gaglani for both helping to edit the script on that one as well as sponsor the video. Vanita's got her own website called Vanita's Rehab, and she's a registered physical therapist who has actually written a book on urinary incontinence. So it's really awesome to have her help with that video. Other than that, you can check out our new subreddit called r/osmosit. We're going to be posting videos to there and having discussions as well. And then you can also obviously subscribe to our channel, like our videos, or donate to us on Patreon. Thanks guys. Bye.